Okay. Man, X picks up fast. That's the quick one in the group. But here we are. It's 8 o'clock, Thursday evening. I'm hot off a 5th grade band concert. Had to hustle over here to get back. Great show. You guys missed out. We had Ode to Joy. We had Twinkle Twinkle Little Star. We had some London Bridge. I mean, it was something to behold. Anybody that gets a chance to catch the 5th grade band on a restream, take advantage of that. Beautiful stuff. So today we're going to shift gears though, and we are going to talk about neurology. And I got a special topic today. It'll be a quick one, so we'll try to handle it at the beginning, and then we will get to some questions. We are back with the higher resolution camera angle. So let's see how that goes. You guys let me know. And then if you could just say hello in the chat. There we go. Eileen, great to see ya. Hope you had a great day. Michelle says, hey, kiddo concerts are the best. Yeah, we had a great time. Super happy to go. Also happy to be able to be here today. So we're going to talk about some fun stuff. I'm going to let a couple people join because the first part of the presentation that I have for you, minus questions, is I think it's going to be interesting. I think you will like it. And I think it'll be useful for a lot of people. Glad to see the bodyguard is here. Nomad over normal in the house. Awesome. Upstairs and rocking it. Greetings from the 2nd floor. Exactly. I love it. So we're having a heck of a day. What a day in Michigan. We are super blessed. So those of you guys that don't know, I get to spend all day with just people I love spending time with, awesome people. And so that's what puts me in a good mood for stuff like this in the evening. So off we go. So today's topic, thought you might like. So earlier this week, we had the opportunity to do like a test, retest sort of scenario for someone. And I think that that's going to be really useful for people because most of the people that are listening to something like this are aware that from time to time we talk about autonomic problems. Go figure. And in the world of autonomic problems, the one problem that seems to get the most press, the most loved version, is POTS. Some of you might have known that. Corey, welcome, welcome. Good to see you. So if we talk about POTS, number one, you've heard me talk about a lot of different depth on how I think about that as an entry point. I think there's a lot of subclassification that becomes really useful if you're actually trying to solve the problem. But a lot of people will have the experience of being prescribed a medication. And in the course of being prescribed a medication, it's kind of like sometimes they work, sometimes they don't. That's the experience that a lot of people have. And there's a trade-off. So anytime that we use something exogenous or external, we have to trade off between like, well, what is it going to give me and what is the thing that's going to take? Because obviously if it was just the way my body ran, I wouldn't need it. But we have a good window into that today. So we have someone that is a relatively young person, about 30 years old, maybe 29 years old. And at 29, they had previously been diagnosed with hypertension or high blood pressure and thought like, everybody here is like, you hear high blood pressure, you think we got to get that down. Sometimes we don't pay attention to why we got to get it down, but normally it's because somebody's at a risk of stroke. And to fight off the risk of stroke, a lot of times it seems worthwhile for people to bring that blood pressure down. But what we're not taking into account is that in any young person, why is the the blood pressure high to begin with? That's a useful question. So in this particular case, that happened to be part of the history for someone who is having symptoms of POTS. And with those POTS symptoms, I'm feeling a lot of things that are very much in the hypoperfusion range, right? So brain fog, lightheaded, all of these things, dizziness, nausea, et cetera, right? All the stuff that makes you feel like you're bogged way down. So what we did was hey, Mary, good to see you. What we did was had a quick look at what's going on from just like an orthostatic perspective, like you guys have heard me talk about before. and we'll see what's interesting. So I'm going to show you guys real quick. Let me see if I can pull this over, if it looks smooth. Now this might, I can never get these to be a really great size because I put a lot of stuff in there. So I don't know if you guys can see that or not. Let me know in the chat, and if we need to, I can move some stuff around, try to make it bigger. Let me see. Let's see if I can slide some stuff here. I don't know if that's helping or hurting. Let's see if we can get all of that all the way across. So I don't know if you guys can see this, but basically what we're looking at here, if anybody's seen me go through one of these before, let me pull this, I'll draw on it a little bit. So we kind of break it down. I break it down like this to explain to people because it's kind of an easy way to visualize it, but we can see over here, all the non-shaded part is someone laying down. And then when in this gray area, then this is kind of like when we're tilted. And then this bottom part of white is where we're laying back down again. So 70-degree tilt, 10 minutes. And we're looking at, sure enough, we see this baseline heart rate around 72. And then immediately in that first minute, we're popping up to 102. And then it kind of settles back in the 80s, and then into the 90s, 87. So the deltas are, 41% in the beginning, and then in the kind of the 20-ish range, thereafter, 20% range thereafter. And then when we look at the blood pressure is high. So, like 148 over 90. And then when we're on a tilt, 151 over 83, 147 over 98. And it kind of stays in that, 140s over upper 80s, 90s range. Cool. And from there, we can see that, so this is like a little bit high. So then we come down here and we look at the medications. We're on Eliquis. And then it's been about 24 hours since the last dose of metoprolol. So for those of you that know, you know, but if you don't, metoprolol is kind of it's a medication that is used as a beta blocker. It's one of them. There are a few different ones. Metoprolol is one of them. It is unique because it's like a beta 1 adrenergic receptor blocker. A lot of words there, but it just means it only affects a certain type of the beta adrenergic receptors. Cool, whatever. We'll get to why, but like I don't want to overcomplicate it there. So what we're saying is like normally taking that metoprolol as a way to decrease this blood pressure, right? And without it, we can see it kind of drifting back up into these higher numbers. So mean arterial pressure is kind of over 100. And so it's like, it's creeping up. And then the question kind of becomes why, right? So we slide over here and we realize that the perfusion rate when we're laying down, left side's about 62. This is using the transcranial Doppler, by the way. So we're measuring middle cerebral artery blood flow using the middle cerebral velocity. Centimeters per second is our metric, okay, or that's our nomenclature. So we're starting at 62 and 60 as the baseline. And then when we tilt people up, we want it to basically stay there, right? And we know how efficient that hemodynamic system is based on how close it can get to that baseline number. And you can see the bolds here. Those are highlighted because they're kind of below where we want them to be based on normals, okay? And so you can see that we're in this little bit of a pickle where our blood pressures are up, but the blood pressure in the brain, or the cerebral perfusion pressure, is low. So that doesn't seem right, right? And then we're getting the subjective symptoms that are being complained about: dizziness, shortness of breath, doesn't feel right, lightheaded, etc. Okay? So if we just stop for a second and go, what in the heck is going on here? You realize that we're not getting a normal transfer of this high blood pressure from the body being transferred into the brain, which means that we're somehow restricting the flow as it comes through the carotids and actually into the skull. That's super important, right? Okay. So we had this conversation. We talked about, that's a thing that we want to pay attention to. And then we said, what we might want to take a look at though is what changes when you use the metoprolol, because the thought would be that it should decrease the blood pressure. But when I look at that, I say, if we're already having a hard time converting a high blood pressure into normal blood flow velocity in the brain, what's going to happen when we go back on the medication and then we drop that blood pressure? Because now it's even harder to get blood flow into the brain. So what I was concerned about was that if we go back on the medication, resume it as normal, then actually these symptoms are potentially going to be worse because of their relationship to the hypoperfusion. So stop me there if anybody is confused or like you got a question. I'll take a moment and like I can take questions specifically on this thing, and then I'll show you kind of what we measured a few weeks later. Okay. In the meantime, you rock, made it. Love it. Glad to have you. We got a question from Fatima that we'll get to. We got another question here. Okay, so we're seeing questions that are kind of coming in around personal things. And then, somebody with some mystical art is visiting us from Toronto here on the chat and dealing with the POTS and trying to get some help. So hopefully we can be useful today. Okay, so it doesn't look like we got any questions. We're basically saying, all right, we got high blood pressure. It's not transmitting into brain blood pressure. What is going on here? So what we did was we went back on the medication, and then with the medication, we want to see, does it make it better? What happens with the blood pressure? What happens to perfusion pressure? What is going on here? Okay, so let's look at that. Sweet, I'm blocking it with my big old head. Give me just a second. Oh, that's not what I want. Let's see, I'm gonna make me just a little teeny tiny down here in the corner. And let's move some things around. Okay, so I'm tiny. This is the same test. So we see here, original one was 5.5, this one's 5.28, so it's 23 days later. We're back on metoprolol. Last dose was 90 minutes ago. This is a morning test. Okay, so this is early, same time for both of these. And here's the part that I think is super useful. When we look at this, we see that this blood pressure is coming down. So we're not crazy low, but we're lower. If we look at the mean arterial pressures here, our baseline is about 10 points lower than when we started out last time. So it does have the effect of bringing the blood pressure down. That was kind of the intended purpose. But if we look over here, what becomes really interesting is from just an observation. Again, this is all just observation, but I think the observation is worth the exercise. We observed that it was much harder to actually acquire the read this time. So to actually find the insonation of the vessel. So that's number one. Number two was it was actually our ability to be able to get that was much lower. So our baseline number was a lot lower. But then we found, okay, well, maybe we just missed it and we made an error here. But when we compare the vessel to itself, which is what we're doing, we see a more significant drop of the cerebral perfusion pressure, right? The cerebral blood flow velocity in this instance. So the numbers go down even more, especially as time goes on. So they start low, they come up for a couple of minutes, and then they start dropping pretty precipitously in the 8th and 10th minutes. And then we see we actually were unable to hold the value here as we started getting into the teens. So the numbers were getting low enough to where they weren't picking up on the machine. And then they, again, in these last 2 minutes, they start dropping pretty hard. So, and similar types of subjective symptoms where we've got dizzy and lightheadedness, we got brain fog, etc. So what I think is a good takeaway from this is we're not saying like, take meds, don't take meds. That's not really the moral of the story. It's not my role in the world. But what is useful is considering how these dynamics work. And if you kind of think about them logically, it makes a lot of sense. So if we get on a medication that is going to do two things, metoprolol tends to do a couple things. I guess I didn't really talk about that. Number one, it's meant to kind of block the sympathetic nerve signal. So we got a couple of them coming in, coming down. They start from the IML in the cord, they come to the heart. And basically this medication blocks them at the SA node, which is what controls our heart rate, blocks it at the AV node, so we kind of suppress it. So that's going to bring the heart rate down. That's kind of the job. You can see that that happens here. Heart rate is lower during the orthostatic stress, right? And then as a consequence, we get lower blood pressure. It also does a job, because it only affects the beta 1s, it also affects what's called inotropy, which is basically the contractility of the heart, like how hard the heart can contract. It kind of slows that down so it actually doesn't contract as hard, which is kind of paradoxical, because what it does is it decreases the cardiac output because it's not pushing as hard, even though it's going to fill a little bit more because the heart has more time between beats. So I'll say that again. The heart has more time between beats because the heart rate is slower. And if the heart rate is slower, that means the heart is going to fill up with blood a little bit more. But the amount of squeeze, right? How hard that heart is squeezing is going down. So actually the cardiac output can kind of be blunted a little bit as well. And we're seeing that here. By taking that heart rate down, we see the blood pressure drop a little bit. And then we see the cerebral perfusion pressure drops even more than it was without the medication. So in this case, what I think we can really take away from this is looking at the fact that we have the capacity. We don't have to just guess on what a medication does in a lot of ways, especially when we look at hemodynamics. We can look and see, does it have the intended outcome? Now, in this case, the intended outcome was kind of trying to suppress blood pressure, but at what cost? One thing to consider is that there's a possibility that blood pressure is elevating because blood pressure in the brain is dropping. So how can I get more blood to the brain? I can increase my blood pressure. And while my resting pressure is going to be higher, I may be able to get more into the brain and actually be able to function. And then if I take that compensation away and I say, heart, you can't beat fast and we can't raise that blood pressure, then we're going to see the perfusion pressure is going to suffer. So the cerebral perfusion is going to go down, symptoms are going to get worse. And I would argue that hypoperfusing the brain is, over the long term, perhaps even more dangerous, because we're kind of like extending that period of injury and also reducing quality of life during that time frame. So again, takeaway for me, and we actually had a couple of these in the last couple of weeks, but I thought we could just go through this one because it was fresh on my mind, is when we're testing people, we want to understand, does the medication do what we think it's doing? And is it solving the right problem? A lot of people will notice that like their particular medication isn't useful for them. And they notice it doesn't make them feel good. And then it's kind of like, then what? Or it's unknown. And is it having the positive effect on the thing we want it to affect or not? So moral of the story is we have the ability to be able to check and see if these things are doing what we want. Maybe we could use it and then we can test and then retest the outcomes of the medication and see if it's handy or not. If that's kind of the model you want to use. We take a different approach. We say we're going to test, retest, trying to train the brain. But you can see how there's a parallel here. And this person's been being pushed for years kind of in the wrong direction. So with this bit of knowledge, now we can start to think about how do we solve this problem in a different way. Cool? So let me know what you guys think about that. If you got some comments, I'd like to hear it. I'd like to know, just like, give me a quick one. Is that useful? Is this sort of thing useful to see if we kind of pull out little vignettes for patients? And let me know. We'll take a couple seconds, and just if you could give me a little bit of feedback, that'd be great. So in the meantime, Double H asked, can there be a blockage in the neck area that's not helping blood get to the brain? Fantastic question. And that is, in some cases, that is the problem, right? And we had a different case today where that was in fact a problem. In this particular case, you can see when we're checking this cervical range of motion with the Doppler, that we don't see a significant change with the movement of the head, which would indicate that perhaps there's something going on in the neck. If it's just in the neck itself, when we tip people up, there's no real change, right? It's because it's not changing. So the way that we stress that is by having people move their neck and see how that affects blood flow in the brain. So really good question there. We also actually do it by raising arms over the head as well. Cool. So really good question. Some of the times that is the case. And sometimes I'll be like, that's got to be what's going on. And then we do the test. I'm like, nope, that wasn't it. And we just keep plugging away and keep hunting for the problem. Good question. Mystical Art from YouTube says, can dysautonomia cause reactive hypoglycemia? Okay, we'll get to that one later. We're going to stay on this topic, but we'll come back to it. Double H says it's very useful as you figure out that there's a reason for the high blood pressure. I think so. And this is one that has just been on our radar a little bit lately because we've had a few patients like that where they're without any, meaning to do it. By solving the high blood pressure problem, we end up making the perfusion problem even worse. And then a lot of people will be on a different medication. I'm gonna switch this over here. A lot of people will be on a different medication, such as like propanolol. Propanolol is a little bit different. It's also a beta blocker, but propanolol isn't selective. Hey, bud, nice job at the concert tonight. Hey, Dad. So it's not a selective blocker, meaning it just goes to all the adrenergic cells. So now it's affecting a whole bunch of stuff. So now it affects your heart, affects your blood vessels, affects glycemic responses. It affects also different changes in the cerebral perfusion and then also cerebral vasoreactivity. So now like something like propanolol, we have to look at even closer because it's affecting all of these different things. It makes it a little bit harder, even though that one's more common to give to people with POTS. It's worth noting that I'm not making any recommendations on medications here. We're just making observations about what we see relative to what we're testing. Cool? Cool. Okay, so I'm gonna go ahead. I'll shift gears now since people don't seem to have any questions about that. We're gonna shift gears and let's talk about some of these questions here. I'm gonna start with, Okay, so Mathison says, I think it's Mathison, says, hi doc, I have a follow-up question from last time. If you got time, I'm sending it right away. What treatments are available for internal jugular vein compression? Okay, so if we have internal jugular vein compression, we want to know what's compressing it. Sometimes this can be something osseous, like a bone, like a styloid is kind of the one that people talk about, where this little bone on the back here has a massoid and then it's got a little kind of pointy part that comes out. And for some people that can get real long. And in certain scenarios, it can actually cause compression. In those cases where that's long and it's just really compressing it, you can see it on an MRV, especially a reconstructed one. And if it's just like clinching it off, sometimes you got to shave that styloid process off. That's number one. Sometimes they can be osseous because you just get like a shift in the positioning of your neck. So if we talked about last time, if that central vestibular system's off, we may actually have these weird positioning of the head and neck that causes a rotation in those upper vertebrae that can cause some of that compression as well. And then, just simple posture related things. So as long as it's not something that needs to be actually like removed, a lot of times first step is like, can we just get things squared up, get everything lined up like Jenga blocks and see if that doesn't help with that problem to begin with. Okay, so that's number one. That's low hanging fruit. The risk is super low. And then payoffs are high. And if it just doesn't work, then you can always go into more invasive types of things. So that is probably the way that I would approach thinking about that. Could internal jugular vein and or thoracic outlet cause symptoms even down the leg? So now we start to get interesting. So if it's just purely based on like the vascularity, that vascularity is probably not going to affect your leg. But if we start to get into things that happen in the spinal column, in the spinal cord itself, and a lot of times if we've got a jacked up way we're moving our neck, you can affect things on the outside, like we're talking about here, internal jugular vein, carotid artery, vagus nerve on one end, and then sympathetic chain coming up. These are the last two are both nerves. And then we can also have on the inside the spinal cord itself, where we can start to generate problems that typically go to the bowel and bladder and to the feet first. So in those cases, if we're actually affecting the cord, then that might be more likely to affect someone's legs. One thing to note is that they'll also, you may have sensory changes, and then you also may notice that we get like these jumpier types of reflexes, and that can be an indicator and lead us down the road toward Lhermitte's sign. So a lot of people experience that. That's a pretty common one. Maybe that would help. Okay, so Fatima, also from YouTube, says, hello, doctor. Quick question. Can an EP study help for POTS patients? An EP study would be like an electrophysiologist, I think is what I'm assuming. I'm going to say that that's probably an assumption, but I think I'm right. So an electrophysiologist is going to go in and measure if there's any errant activity in the heart. Meaning when we send electricity through it, it should be orderly. Sometimes we get blockages in different portions of the nerve or blockages in different parts of the heart where they're not contracting. And sometimes it can skip and like arc to another spot and cause like fibrillations or arrhythmias. So for someone to be diagnosed with POTS, we kind of have to rule out that they don't have a predominant cardiac problem. So we want to rule that out first. A simple EKG is a lot of times the starting place. We'll do a long run EKG. And we just want to see if there's any weird waveforms, especially if you got like a 12-lead Holter on. And you can see if there's weird waveforms, and that can prompt further investigation to see if we need to look into getting an electrophysiology study. If the EKG is pretty normal and we're not seeing that, then a lot of times the EP isn't warranted because you will usually see some evidence that something is wrong with the electricity through a 12-lead. Or even a Zio patch, something like that. So if you have like POTS, usually they've ruled out that there's a cardiac-based problem, and now we're coming up into the neurological and hemodynamic system as the point of error. Cool. Okay. A nuclear stress test. Is it safe? It does sound scary. It sounds like you're about to get, Hiroshima or something like that. I don't think it's something that needs to be particularly worried about, especially if the upside is you get information that helps with your particular problem or your particular treatment. But I don't know your story per se. But as a whole, it can be a useful test if it's applied for the right type of case. So maybe a sigh of relief there. Does selective serotonin reuptake inhibitor relieve autonomic disorder symptoms? If yes, does it have a long side effects? This is something you can read about. There's actually been some really good papers in the last couple of years. And it's questionable what SSRIs are doing as a mechanism. So that is probably worth taking a read on. Does it relieve autonomic disorders in general? If we're in the peripheral autonomic system, then it's not likely to. These are central activating systems. They were developed on the theory that there was a chemical imbalance in the brain. A couple years ago, I can't remember the name of the study offhand, and I don't have it on hand right here. But they kind of went into studying this idea and kind of came out of it. It was a pretty popular study. I think it was in Nature. I could be wrong there. Someone can fact check me. But basically looking at SSRIs as number one, that the chemically mediated, or like we have a chemical imbalance idea, has kind of been refuted. And then it has been called into question what exactly an SSRI does. They do have a long list of side effects that can be pretty difficult, so it's worth investigating if you're considering one. Again, I can't give advice on this one way or the other, but there are definitely plenty to read that can help to fill out an opinion as to whether or not you think it'll be useful for you. But as far as addressing the autonomic disorders themselves, there's a pretty low likelihood, given the relationship of serotonin in these systems. You may be looking at like a secondary or an adjacent effect in these conditions. Okay, I danced around that one a little bit, but that was kind of like a CYA answer in a way. Okay, so I apologize for that, but go read about it. Okay. Mystical Art asked again. Another question. Can dysautonomia cause reactive hypoglycemia? I'm not diabetic at all. POTS started with reactive hypoglycemia and then histamine intolerance, then full-blown POTS. So this is probably a good place to step in. So reactive hypoglycemia basically means that we're not having a stable glucose level. If we're not having a stable glucose level without eating, a lot of times we can start to get a drop in glucose levels, and then when you eat, they can come a little bit high, and then we can go through these cycles, and that's the idea. Basic way to think about that is, in an ideal world, when you get hungry, you should just be hungry. You shouldn't be hangry. When after you eat, you shouldn't have any real change in the way your brain works. You should just kind of keep rocking and rolling. That's typical of this. If it started with reactive hypoglycemia, that may be the problem, but it's not likely to be the problem relative to POTS. It may be a problem relative to what you're experiencing with energy levels. Histamine intolerance, does that mean that you don't eat histamine? Does that mean you don't? I don't know what the intolerance side of histamine means, like you don't tolerate your own histamine, or you can kind of let me know about that, and then full-blown POTS. So we may be looking at just the sequela of how these control systems are breaking down. If you're seeing multiple organs start to fail in their ability to regulate automatically, then you want to trace back to where do those things all kind of share commonality, and then work from there. Simple things with diet can be really helpful with reactive hypoglycemia. And if that's what you're noticing, that's probably the problem to solve first. And then the question would be like how those are related to POTS. So you'd have to really kind of start to dive into measuring these things, grabbing the reality of them, and then seeing where they relate. But a lot of people have that milieu, but maybe assigning like causality to things that may or may not actually be causal. Okay. Madsen had a good question about what we were talking about before, asked about how does Vabberdine play in. So this is kind of like the sequela of using medications where you're kind of like a little of this and a little of that. I poured too much salt in. Let me put a little more stock in, right? Oh, now I don't have enough chicken, so I throw too much chicken in. Ah, crud, so now I got to put more stock in. And then you just like, next thing you know, you got a pot of soup that's this big. So how does a Vabberdine play? And a Vabberdine's role is this funny channel blocker. It basically increases the contractility of the heart. So it's mostly used in, well, it was designed to be used in, well, is most applicable in cases of heart failure where the contractility of the heart, like so in heart failure, you just like, when you go to activate the heart, it just doesn't have a lot of muscle left to really rock out. So Vabberdine is basically just like juicing that system so we can get as much contractility out of the heart as possible. Interesting thing to think about then is well, we're taking a healthy heart that's already working real hard because it's beating real fast, and then we're just going to say, let's crank it even more, and we'll just beat it harder. So that's fun. So it allows the heart to fill a little bit more and get a little bit more of an ejection fraction, which can increase cardiac output, which is why some people report benefit. But then you got to look at like what you're trading in for that, which you got to make a decision on. So that kind of brings us to the next one, which is from Double H here, that says that's what happens when you treat symptoms, not the cause. Poor guy was pushed to try to keep reducing the blood pressure, which is important, but it's hurting somewhere else. And I think that's like the moral of the story with a lot of these things is you're giving and taking, because I think about these problems a little bit differently, and it may be useful to you, it may not. But I don't think about our body as like it's failing or fighting against us. I think about it as like, oh, it's trying to solve a problem. What is the problem that it's trying to solve? Now, maybe that problem is causing symptoms in another area, but those symptoms are designed to like indicate to us that something is wrong, right? If it was evolutionarily ineffective to have feelings of negativity or feelings of symptoms, we wouldn't have them because it costs energy to have them. But they give us a way to understand that something is wrong. And so to assume that our body is just like, thumbing its nose at us and saying, forget you, I'm going to do something different, is I just don't abide to that. I think more realistically, your body's trying to compensate in whatever way it can that gives the best outcome given the current scenario. So going back to our case from before, cerebral perfusion pressure is low. You don't want to pass out and you want to be able to think, what can we do? Let's try to create more blood pressure and hold this person upright. Yeah. And that's the problem it's solving for. Now, on the downside, you're probably going to get out of breath because your heart's beating real fast like you're exercising. It might cause some problems because the blood pressure's high, but also it's saving you from falling over or having to live your life laying down in bed. So like that's a trade-off. rather than trying to solve for the blood pressure problem, maybe we try to solve for how can we train them to be able to not have to work so hard and get more blood flow in their brain. That seems reasonable to me. So Vabberdine, we're just kind of like juicing that system, saying we're going to increase the cardiac output without really considering why the output is low to begin with. Good question though. I really appreciate it. This is kind of like a topic that can make some people feel, I don't mean to ever make anybody feel bad or left out or like they're making a bad decision, nothing like that. We're just trying to consider a different way to think about things. And if medication's a thing that works for you, do your thing. That's great. But what we're finding is just a lot of people aren't served by that. So we're just providing maybe a different way to think about it that's a little more empowering, that allows us to kind of get to something that may be useful for those people. Ritvik says, thanks for walking us through the spreadsheet. Do you eyeball the number to assess how to proceed, or is it a software that you use? Yeah, we use a software. So actually all of these are being continuously captured. And then we have a Doppler study that we're kind of like, we're snapping photos out of, and then we're able to report on those. But yeah, I'm not smart enough to do this on my own, but we were able to capture it all. We drop it into the spreadsheet as just a way to communicate it a little bit cleaner than the raw data. We're looking at other ways to do that, but this has been the one that that we've had the best luck with not being overwhelming with. Any opinion on the use of steroids as treatment for an ocular stroke? Ooh, or can that be rehabbed in a different way? Okay, so an ocular stroke being a stroke in the eye. So sometimes what'll happen, so typically if you're gonna, I'm gonna go a little deep here because I think it's good. So if we have a stroke that goes to the eye, we have two types of strokes. First type of stroke is where we block the artery, right? So it's like you got a tube and then you stick a rock in there. These are the kind that we typically think about, like a clot or a plaque breaking off, going through the arterial system, and then it just gets lodged in a small artery. They happen in the eye or in the retina because things will come up through the carotid and then get jammed in that ophthalmic artery right behind the eye. And when that happens, it goes black. And we actually have to work pretty quickly on those to try to get the clot breaker. And these are where our medical system, our nurses, our ER personnel are really good at trying to break that clot so that we don't lose an eye. Really important. The second type is kind of the opposite. We're still blocking blood flow, but in this case, it's that we're kind of closing it off by over constricting the artery. And when you over constrict the artery, the same thing happens where we start to lose the perfusion of the retina. But in this case, we're kind of like, how do we get that thing to dilate back out and not be spasming on us like that? These are the ones we see more commonly, especially in our hypoperfusion cases, when we see in period. And then the second part of that statement is that it can be affected differently on different sides. And this is where you'll see us check color vision on one side versus the other. And people will notice that like one eye is a lot less sharp than the other eye. And head movement may affect that, or different activities or vestibular activity may affect that blanching of the system where the eye isn't perfused as well. These are more functional problems. And what I mean by functional is that it's like an overconstriction. It's a hyperactivity where the normal reflex is too sensitive and it constricts down fast, causes that blockage in the eye, and then we see those ocular types of migraines. If it lasts long enough, then it can become a stroke. So I would differentiate those two things and say, if we've got someone that is in an active occlusive stroke where we've got a clot or something that's blocking the artery, in the acute phase, you got to get that out of there, try to save their eyeball so it doesn't starve. If in the long term, we're noticing that their vision was affected, but the eye is still reasonably healthy, then you can do things with light stimuli to try to target whatever portion of the retina is affected. There is some really cool technology available that can help you map your visual field. We have a great partner that we use here in town that we send cases to when we need to get them mapped. It's Cherry Optometry. Shout out to them. We love them. and they can map that out, and we can actually track progress. And you can, based on wherever the field is that's affected, you can target that by where you apply the light, and you can just do small dose light responses to try to see if you can pull that out of people a little bit more. If we're noting that the problem is that we keep having these strokes where that vessel is just unruly, then we want to do things that help to be able to slow down the stimulus of that vessel so it's not so reactive. Here's where we start to think about autoregulation, vasoreactivity, some of the things with hypoperfusion that we talk about more. So there's kind of like a couple different tracks to think about, whether, how you're going to try to skin that cat. But from a neurorehab perspective, if there's healthy tissue there, we're going to start with a really low dose. We're going to try to introduce light. We're going to try to introduce motion. We'll start with like a low flicker rate. We'll try to target it toward areas that are adjacent to the affected area, and then move them into the affected area and try to pull them along that way. So great question. Nomad over normal. Check them out. I wonder, do you have... So one thing I learned, I'm going to do a little bit of a plug because I learned a lot about them. Go check out the LinkedIn on that profile. Excellent YouTube skill set out of this crew. So if anybody's looking, great team. Go check out Nomad over Normal. Just awesome. Christy Lee says, explains why many feel worse, way worse on a beta blocker. And that happened, like a lot of the people that we see seek us out because they're like, we tried all that stuff, it wasn't for me. And then so we have to say, well, we have to figure out this problem in a new way. And that's how we end up here. Okay. So Nicholas Lyman up next. He says, hey, doc, exclamation point. I think I said it right. Hey, doc. Could you explain why POTS creates a sensation of the neck getting tense or difficulty with breathing? This can happen from a lot of different ways. So, where to start? Let's talk about it in terms of the tenseness related to the difficulty with breathing. A couple different ways to think about it. Number one is just simple mechanical stuff. That's less common, where all of it, like, because that doesn't kind of happen out of nowhere. Those are things that build up over time. But a lot of people will know that as that starts to, so like in a flare, or if we're in a POTS situation and we have some type of an input, you can think about this as just a bandwidth problem. So some people will notice it when they're driving, walking through their grocery store, thinking too much, they're in a weird posture. They might notice that the breathing starts to get tough and they start to feel tension in their neck. If that's true, then we've kind of exceeded bandwidth and we started to get a dysrhythmia with the breathing rate. And a lot of people will feel this. They might also feel like they get a lump in their throat. They might feel like they can't get a full breath. They might feel like the ribs are tight. So there's a lot of commonality there that is relative to just simple like overstimulation, not enough bandwidth to tolerate it. So those are tricky for people because they can feel like, I don't know what causes it. It can be anything, but it's just like an exceeding of bandwidth. So that's kind of one. So if we're trying to think of how do you reduce that in the moment, the simplest thing, and this is a very, very general strategy, is just to literally cut bandwidth. So laying down, covering your eyes, taking some breaths, trying to let that work its way out. That's like the things you can do at home. Somebody here had an experience today where we could look at that same as a GI related thing, but with breathing, whereby giving different stimulus into the system, you can let it get some feedback and kind of recalibrate that breathing rate again so that the rate that's happening in your brain starts to match what should be happening in your diaphragm, matches what should be happening in the accessory muscles in the neck, and then you can kind of resort everything. So that's like the simplest way to think about it. People that we get a chance to look at, we can usually observe some things that can change a little bit faster, but it tends to be more specific to whatever they're going through. But recovery position is like my general kind of lame answer. Laying down, covering up your eyes, trying to breathe slow through your nose, putting your legs up on the wall, and just letting everything kind of calm down again. Sometimes that's the best way, but it doesn't work for everyone. a lot of times we can find more successful things to do, but it's hard to know without looking a little deeper. But it's a good question though. Okay, Mystical Art from YouTube says, my doctor put me on propanolol and it was horrible. I tanked my blood pressure, affected my asthma. Now they want to give me midodrine and Vabberdine. IV also developed SVTs due to POTS. Yeah, so that's kind of a pretty common one. I try to really stay away from getting too deep into the medical conversation here because I don't prescribe them. But I mean, so we're going to if we slow the heart rate down, then we have the propensity to possibly cause more symptoms, possibly decrease the blood pressure. So then what do you do? Well, and also, okay, so when you look at propanolol, we're going to get a little bit into this, but not super deep. When you look at propanolol, because it affects way more stuff, it's also going to have like a harder profile to manage because it also affects arterial constriction. So it can cause some difficulty with managing like just normal pressure because we see an alteration in like peripheral arteries. We can see that it affects the ability to react to CO2 in the brain. We can see that it affects glucose levels. So like it starts to affect a lot more stuff that becomes harder to manage. That's number one. So then number two is you say like, well, if that's true, we'll drop the heart rate down. We're still not getting where we want to get to. So we'll add midodrine, which basically does the opposite and causes constriction. Just like we're just going to cause all of it to the peripheral vasculature. So it's going to crank the pressure up and you're just going to force feed it. Now, that can be effective for some people because it's just enough to push through that hypoperfusion that it kind of gives them a window back into the world, which can be really helpful. Then they'll use a Vabberdine to give a little kicker so that you can get more out of your heart and increase the cardiac output. So if you can increase more output with a tighter vasculature, then hey, that's pretty cool. But now we've just got like a fully synthetic system that's just running hot all the time. And if that's still not working, or they might choose to use this earlier in the game, then they'll add usually like a steroid like fludrocortisone that causes you to hang on to more salt, which increases the overall blood volume. This doesn't start to get into how metoprolol and propanolol actually affect renin outputs so they can affect volemia, which is kind of wild that we even do that. But here you go. And so then the hope is that, we'll use that medication and just like artificially expand your blood volume, and then you'll just have more blood. So we just make your heart crank, make your vessels crank, we put more blood in the system, or we just like dilute the blood and put more in the system. And then we just hope that solves it. And then we do this in teenagers and hope that like that's going to sustain itself for a lifetime. So there you have it. And then you get this weird stuff that's going on where people use desmopressin, which is like, it expands blood volume without taking salt up. So if you do the math on that, then we basically dilute the salt out, we become hyponatremic, and then you can actually get like real problems where you can affect the heart and you can affect the kidneys, and we can actually start to like get dangerous. So then that's the new one that people are talking about, that you can tell by my tone how I feel about it. But anyway, that's just my opinion. You can do with that what you like. Anyway, Melissa, hola, dígame. Good to see you on here. Love it. We're just having fun. Yeah, so the medication stuff kind of puts me in a bummer because it makes me bummed out. I'll try not to talk about that as much. Ridvik said, have the spreadsheet numbers varied in the past few years with more infection-associated POTS patients coming into your clinic? Thanks for a super clear explanation. I mean, the origin, like how things happen changes with infection versus an injury. You can kind of start to parse some of that out. So that's a thing. But we're always trying to like, there's this book by Seth Godin called Sacred Cows. And it's basically your sacred cows are like your ideas that you just like hold to be true no matter what, like gravity and blue skies. But what we're trying to always do is look at these things in a way where we're saying the things that we think we believe the most, how do we try to prove them wrong? And we just try to do that all the time. And if you're not married to things, then it doesn't really matter. You don't get hurt about it. And if we can prove them wrong, great. Then we learn something and we go on to the next thing. So that's what we're always trying to do. And so lately, well, not lately, in the past few years, we saw a surge in people that were more aware of like infection related causes to these things. So they were happening before, just nobody knew where to steer them and they didn't know where to look. So they would get dumped into other buckets, with autoimmunity and Lyme disease and mold and all these things that for some people may be true, but a lot of people are just getting bucketed in there without a real clear explanation for why. And then people started to talk about like long COVID and POTS and realize like, oh, like this is a thing. And so a lot more people, like people became way more savvy in what their options were, and that became really helpful for people to be able to start seeking out new answers to those problems. So that was actually probably better in terms of like getting people awareness and access to some of those things. And Ripvic also asked, oh, you were going right here. What are the top 1 or 2 things you would want doctors to know about POTS who are not as knowledgeable as me? I don't know. That's a good question. It makes me feel like squirmy to say that people aren't as knowledgeable, but just maybe people that are newer to the discovery process. I would really like people to think about POTS as a starting place. Like that diagnosis should not be what we're treating people based on. That's my sense of it. It is the place that like gets you in a bucket that starts you in a direction. Like there's a problem somewhere around here. Let's go figure it out. That's what it tells me. And I think if we treated it more like that, that would be super useful. And I think if we looked at it in a more mechanistic basis, then that would be super useful because I think we would get people to help faster. That's what I think. And Christy Lee said, if it's not too off topic, is there a link between dysautonomia and oxidative stress? So let's talk about that. Most people are familiar with dysautonomia as just being a problem with autonomic outputs. Oxidative stress is looked at, it's like carried some different definitions over time, but what we're basically getting to is the accumulation. Well, let's talk about it like this. So oxidative phosphorylation is basically the long way to describe how our mitochondria take glucose and oxygen and turn it into ATP, which is like our unit of energy. And then it off gases water and CO2, right? So that's like Krebs cycle cellular metabolism in the fastest way I know how. So oxidative stress is like kind of part of the Krebs cycle is we kind of throw off reactive oxygen species, but then we actually use those later on and we scavenge them to create energy through other systems. So it's like it's kind of like if you're making boards, as I don't know if this is going to land, but if you're like in a sawmill and you're planing out boards and you're kicking off sawdust and you got this big pile of sawdust over here and you're like, oh, we got to spend a bunch of energy shoveling that up, get rid of it somewhere. What are we going to do with it? And then you go, no, what we're going to do is we're going to collect it right off the sawmill and then we're going to package it into little pellets that people can use to cook on their Traeger grill or put in their stove so they can heat. And then we'll just like without much energy, we'll automate that and we'll use it for something else. And that's kind of like what reactive oxygen species do. It's just like a different like conjugation of that oxygen component. That's a silly way to say that, but basically we use them in other ways. We talk about reactive oxygen species as like a cellular debris, but we actually we've kind of come a little bit further in that knowledge base, and we understand that that's actually like part of how we use fuel systems and why like glutathione, people have usually heard about that, why people get excited about that, because it's like a conversion process for that, and it's kind of like a natural portion of a healthy cell to be able to convert that sawdust, so to speak, into something functional. Really good question. But how do they relate? How are those two things similar? Is, well, if we start to have mitochondrial heteroplasmy, which is kind of like where we get modifications of mitochondria that may make them more or less efficient, then we can start to change mitochondrial outputs. One of the things that's most important to that, though, is how you activate a cell. This is neuroplasticity. So if you activate a cell effectively, it allows you to be able to generate genetic changes in the cell that make it more resilient, make it stronger. If we do not activate a cell, then we see where these things start to decay and the actual substrate within the cell becomes less, and it becomes less efficient, And then we see real changes in oxidative phosphorylation where the cellular health goes down. So these are actually what we see when we're looking at these functional lesions where people just don't have the effectiveness within the cell. And the way that we resolve that is by trying to get an increased level of stimulus so that it can strengthen and get stronger again. This might be something that we need to talk about in a long form because it's super useful and it like changed my life to start to learn about it. So thank you, Dr. Carrick. But yeah, understanding that when you're thinking about doing rehab, you're actually thinking about the quality of that cell and its ability to like live in its own ecosystem. By stimulating it, we bring in protein, we bring in synthesized energy so that we can use that cell more efficiently. We can clean it up, dust it off, make it work better. So that's one of the beautiful things about our brain is that when you activate it, it makes it healthier. When you deactivate it, it makes it less healthy. So what is the obvious choice is to try to use an activation with which you can make the cell stronger without fully depleting it. Thank you. Oh, hello, Melissa. Okay, Ritvik coming in strong tonight. Love it. Okay. I always feel comfortable asking a question, knowing your answer will be clear and comprehensive. Thank you. Oh, you're buttering me up. This is going to be a good one. Just teasing you. I'm assuming a fair number of POTS patients are taking some sort of blood pressure, heart rate related medicines when they come to the clinic. As you begin healing them, how do you approach getting them off the medication? So in those cases where people are on that, we don't actually change anything in the beginning because we don't want to overcompensate the variables and we want to make sure that our change is the change. So we don't change the other variables. Then what we do is we try to empower the patients to have a conversation with their prescribing physician to kind of loop them in on the process so that they can take advantage of that relationship with that physician to modify the medications as needed. And we're always happy to talk to the prescribing physician to give them kind of like, what is our insight that we're seeing with boots on the ground? And a lot of times those experiences are really great. We've had great relationships with the physicians. They're usually super happy to hear about what we're doing. And then more than thrilled to try to work through that problem set for people. So we've been really lucky in those interactions and just trying to help people in the most efficient way possible while also not, trying to create an override, step on any toes, or like completely throw off somebody's system. So what's cool is being able to measure it, measure the changes even despite the medications, and then be able to take that data in and make it more useful. So good question. I like that. Melissa says, to contribute to this live with my own experience, I was prescribed a tricyclic antidepressant at a high dose because of being diagnosed with a vestibular migraine. I had also been diagnosed with POTS by a different doctor. The tricyclic did not improve the vestibular migraine and worsened the POTS greatly. Can't wait to finish weaning off it. Perfectly placed. I don't know that you could have put this in a better spot in the chat. Well done. And yeah, I think that is like the wonderful, responsible way to look at it is how do we do things in a way that we don't upset the apple cart, especially dealing with neurotransmitters. We don't want to like have those oscillating in any meaningful way because it can be hard on a soul. So thank you very much for sharing, Melissa. SLB. Ooh, I want to make up a name so bad. But SLB. I was diagnosed with vestibular migraine. Well, you guys are getting together on these. I like this. I'm gonna skip this for 1 second because I saw Melissa also said, plus the symptoms from weaning off the tricyclic have been worse than the side effects of being on the medication. And that's just personal experience. I think a lot of people share that experience. So it's really useful to be able to like hear from people on the ground how that's going. Thank you. SLB said it was also diagnosed with vestibular migraine. Meds didn't help, got really dizzy, driving and in busy stores, mostly just home now. Yeah. Vestibular migraine, we should figure out if that's what it is. So a lot of times if we have a migraine, you think about it like a headache, like it's not all the time. It comes and goes, it's episodic. And because when we think about a vestibular migraine, we're thinking about those little arteries that go to the vestibular nuclei or into the peripheral ear. From time to time, we'll do that thing like we talked about in the eye where they'll cramp. And then whew, I start feeling like I'm on a roller coaster, right? But then eventually that should kind of wear out, and then there's a little period of normalcy before you have another migraine. They become this like wave of episodes. So if it's constant, that's a little tougher. And then it might be worth like figuring out if that is in fact a migraine or if there's another cause. We find that we tend to see a lot of people that are diagnosed with vestibular migraine, but don't actually have vestibular migraine. It's just kind of like a catch-all diagnosis that is being used by some people. Not by everyone. There's some great doctors that nail that diagnosis, but there are some that that use it a little liberally. So it's something to consider, especially if you're finding your home and it's like a persistent thing. That might be worth digging into. Okay. All right. How are we doing? So right now we're doing great. Okay. Ooh, I knew this was gonna happen. Probably didn't think it through well, that we'd probably end up in a medication conversation with someone who's not a medical doctor. Great advantage in my life, but I have to be careful in these conversations because I don't want to construe as though I'm giving you like prescription medicine advice. I'm just like sharing some observations that we see. And then also these things are like, also you can read a ton about all of this stuff. So it's not as though you got to have like some decoder ring to be able to understand it. You just look at the published paperwork. There's a ton of it and it's very clear. We also have AI systems that help us learn at a pretty high clip too, right? So you can also use those things. Okay, how's Mestinon, or, oh, I hate this one, pyridostigmine, I always say that wrong, used in POTS treatment? I heard it stimulates the parasympathetic nervous system. So, okay, like eggshells on this one a little bit. Okay, so if we're thinking about stimulating the parasympathetic system, we want to assume that the parasympathetic system was defaulting in some way, which was therefore causing the symptoms, which is not often the thing that is happening unless we're just seeing this runaway tachycardia that is there all the time, not just specific to posture. It's just kind of cranking all the time. And if that's true, there are ways that we can stimulate the parasympathetic system without that. Yeah, Mestinon is not as common in my dealings as it used to be, but that's a good question. I'm shying away from it a little bit because of a lot of this is kind of based on the thought that the sympathetic system and parasympathetic are counterphasic to each other. They're antagonistic to each other. The concept was actually really well described by a gentleman named Wilfried Janig, who's a German fellow, wrote a big, beautiful book in 2006. It was published on autonomic disorder, or on autonomic syndromes. Great book, tough read, but really wonderful. But he talked about this idea of paired antagonism, and the fallacy that accompanies that is that there's kind of this presumption that the sympathetic system and the parasympathetic system like are in a tug of war against each other. And that picture, or they're like on a teeter-totter against each other. And that viewpoint is one that is like easy to stick in your brain, so it gets used a lot, especially in popular cultures, popular culture, not cultures. But it's not precisely true. When we look at sympathetic and parasympathetic outputs, they actually work together and kind of work in their own separate things. So they're all like just the same way. You've got motor nerves that are going to your left hand, and you have motor nerves that go to your right hand. And if you cut them out of somebody, they would look identical to each other. But just because of the same nerve doesn't mean like every time I move my left hand, my right hand also moves, or every time I move my left hand, my right hand has to be still, right? So we have the ability to run them both independently in whatever way that we want to if things work well. If we notice that things are starting to be decoupled or coupled that shouldn't be, now we have problems, and that's kind of where this starts from. So some of the thoughts around like, oh, well, if I can just pump up the parasympathetic system, I'll solve what I presume to be sympathetic overload, which is also not true. because that presumes that all sympathetic activity happens in an all or none way. And that's the second fallacy, the all or none fallacy, where all sympathetic activity or all parasympathetic activity doesn't happen at the same time. They all are on individual tracks. They are all, it's all individually activated. Where we see a problem is if we're trying to activate one and we get more than one to activate, where they start to clump together, then we know there are problems in the way that the brain is generating that signal, because it's spreading it and becoming generalized. So this question really harkens back to that and saying, like, what is the utility in actually trying to stimulate that parasympathetic system relative to a POTS diagnosis, unless we're just having a full decay of the drive coming through the cardiovagal outputs and just allow a runaway activity of the heart, in which case then we'd want to solve for that problem there. So great question. Super common. I've talked about this a lot in the past. I think that's why I glossed through it a little bit there. But those two fallacies are two that drive the world of autonomics, that without them, it helps to make everything make a lot more sense if we don't use them. So the two are paired antagonism fallacy, that they work in opposite, like sympathetic and parasympathetic activities work in opposition to each other. It doesn't work that way. Same thing, all or none doesn't work that way. So you can, the simple one that I usually give is like, you can increase your heart rate, but not sweat at the same time, even though those are both sympathetic nerves, right? So if I'm in the cold and I'm exercising, my heart rate may go up, but I don't have to sweat in order to do that, right? So they don't have to be linked. But also, if it's hot out and I'm exercising, I can sweat and get my heart rate up, both solving those individual problems. Where it becomes problematic is if it's cold and I get my heart rate up and that forces me to sweat, then now I know something's awry, something's decoupled from what should be happening. Cool? So I hope that's useful. It's a little bit of an aside, a little bit of a journey through the woods, but thanks for coming with me. Okay, Grace. Grace says, could you please explain why someone with autonomic problems, particularly orthostatic intolerance, feels terrible with cardiovascular exercise, but can feel better with strength exercise? This can happen for different reasons, and I'll try to do my best here. So cardiovascular exercise is actually usually the one that smokes most people with orthostatic intolerance. Strength training, if the baroreceptor systems are active, that bearing down of strength training can actually cause the retention of blood or pushing blood into the brain. So some people will actually feel better doing like a Valsalva or bearing down because they push blood into their head and they're like, oh, that feels better. Whereas other people will do the opposite. And you've seen these like videos of people deadlifting and squeezing really hard and then they pass out, right? So some people that don't have that same quality of baroreceptor control may notice that when they do something like bearing down, they feel really bad and gross too. With cardiovascular exercise, feeling bad, we want to first, like, are you upright while doing them? Or is it also happening when you lay down? What does the vasoreactivity look like? So the response to CO2, how's that doing? That can cause some of the problems as well. That's really helpful. And then the second one is if you're just already gassed and having a hard time getting blood to your brain, your heart's beating real hard, and then you just like further do that, then most people don't really do well there. It just overstimulates the system. Really good insight though. And that's one of the ways that we actually test it, is by using that bearing down or that Valsalva maneuver to measure the baroreceptor responses. Cool. And we've used that in the past where we can use that Valsalva and then do activities as a way to push blood into the head for certain people. Dancing P, I'm diagnosed with mild POTS. Interesting. Anyway, tried Midodrine. It didn't help make me feel better. Just gave me a weird sensation in my head. I already have 24/7 head pressure. No, don't want any more symptoms. Discontinued med. Yeah, I can understand that. Yeah, especially if you got pressure. Midodrine is going to crank pressure, especially when you lay down. That's one of the things that tell you not to do, is take it and then lay down, because it's just going to keep cranking pressure even though you're laying down. So it's just like one pressure all the time. You Rock says, in bed on the left side, covered, feeling fine, but time to roll over, turn on to back, then immediately get tingling all over, especially thighs, and hot all over, have to uncover completely. Common POTS symptom? Double question mark. Okay. Common, maybe not necessarily common in the world, but is it a thing that we hear about? Absolutely. Like, so one of the things that people kind of sleep on is posture changes matter when you're upright because we can see what the hemodynamic system does, but also posture positions laying down, just looking at how we're oriented, are also a big deal because we can see if there are changes with the compression or signal rate coming through. So what we talked about earlier, am I compressing the cord? Am I compressing arteries? Am I compressing veins or nerves that are in the neck or in the back or spine? And a lot of times, as we activate that arousal system, we get super hot. Tinglies are usually, not usually, tinglies can be a sign for some people of spinal cord activities, or they can be like stuff falling asleep. Either way, we tend to be looking at stenosis or things that are being compressed. Might be worth taking a look at. Cool. SLB says, I have very low stroke volume. Would you recommend that med to get my heart rate down? I don't know, and I can't make a recommendation on a med. But he also says, Rock says, thanks for these streams and learning so much. It makes it more helpful. The quality of life can actually improve. Awesome. Yes. Love that. Ooh, okay. So new one from Das Kit. I've been having severe blood pooling in my hands and feet since I quit caffeine 6 months ago. Is there something I can do to reduce these symptoms? They weren't there until then. That's interesting. It's interesting timing because I had a conversation today about someone who noticed a similar thing, that caffeine had an effect on kind of the orthostatic intolerance that they were experiencing. I would like to know more about it. Honestly, this is like a fun variable, but it's not all the variables. First question is why quit caffeine? And then maybe talk a little bit about how much caffeine or what it was doing, and then pooling in the hands and feet. You want to look at the venous system. Is there insufficiency? Is it getting compressed? Are we getting a reaction to something? Is there anything else that happened around quitting caffeine? From a dietary perspective, sometimes there's another thing when people quit caffeine because we try to do a lot of stuff at once, getting healthy. And then looking at sleep quality, looking at allergy responses, all sorts of things like that. So hard to be able to pin that one down, although it is an interesting one and I kind of want to try. I'm not going to do it on the internet, but I'm glad you asked. I wish I could give you a more clear answer, but this is a tough venue for that. So sorry, man. SLB says very useful. Okay. B money. How common is chest tightness with POTS? I've been checked out by a cardiologist. They found nothing wrong with my heart. I've been experiencing chest tightness every day. Is this normal? Okay, so again, we probably need to remember, I can't give anybody specific medical advice. I'm just a guy on the internet. Don't take advice from a guy on the internet. And also it's not allowed, so consider that. So, but the general question of is chest tightness common? It is common, but it's not always common for the same reason. Some people will feel angina, which is where they feel like they've got pain in their heart. And sometimes that can be from ischemia in the heart, which is something that you definitely want to be aware of. If it sounds like you've been to the cardiologist, hopefully they've done just a brilliant workup on you and found nothing wrong with it, which is really great. Then we want to consider different etiologies that would be related also to pain in the chest, whether that's isolating down to muscular pain, whether that's down to sclerotogenous or dermatomal pain. Then that can lead you to understanding where to look from there. So you kind of start to bundle it down. So pain has to come from, so it has to be some sort of a signal. So you have to figure out what type of signal is generating it, what type of tissue is generating that signal. If you know the type of tissue that's generating it, then you can track it down to where that tissue might be, and then you can start to problem solve with why is it giving you that problem in the first place. But it's a common sensation that people will have. It's super uncomfortable and it can make people anxious. So I'm sensitive to that. I know that sucks. I know it sucks to just feel hard to get a deep breath, but the way you solve for it is by figuring out what is the generator of the pain first, what type of pain, what quality of pain, where's it coming from, and then from there, then you can figure out like, okay, if it's coming from this type of tissue, where is it located? You start searching down the levels, and then once you can isolate that, then you can figure out why it's happening, and then try to intervene in that. Okay, I know that all feels very general and abstract, but like to give you an example, if someone's got like a chest pain but it radiates around, we might find it's neurogenic. And if it's neurogenic and it's coming from back here, we might find actually like it could be relative to something that's going on in the spine. It could be relative to like someone coughing and hurting a rib or irritating the nerve, or maybe they've got inflammation from like shingles, like a herpes zoster type event, or maybe it's just from ischemia within the chest because we're getting hypoxia the same way we do in the brain, and then it starts to hurt in the chest. Or maybe we've got, costochondritis, where the actual intercostal cartilage is irritated, and then that gives you the chest pain. So it's like you're just trying to hunt down and search where that is. Okay. Peace, love, mung bean. Hello. How would you choose between candesartan and midodrine with a reduction in upright cerebral blood flow? I wouldn't choose between either of them. I'd choose not to use it. HH, why don't you open a clinic in another state? Actually, I know you're asking that kind of like a little tongue in cheek, but there's actually really, I've been asked this a lot. We've been asked to by like people that want to help us develop that. Where the reason we don't, I will tell you, is because we want to maintain our standards. So I can't be in two places at once. And right now, the way that I feel comfortable being able to manage standards is by being able to participate for everyone. And we have several great doctors that work in the office, and they're wonderful, and you guys would love them. I haven't had them on yet because they're super shy, and every time I ask them to come on here, they try to find an excuse not to, but we'll get them. They're probably watching this actually right now. So you're on. You're going to be up next week. Anyway, but that way we can really hold our standards high and use that as a way to continue to get better in one facility. I'm not confident that if we tried to open up a second facility that we could maintain the standard, and then that would stress me out and I would feel like we're not doing a good job. So we found it a little bit easier to try to make a hub where we can try to excel in one place and consolidate brains in one place so that we can use them to get even better. So I know you're just kind of kidding around there, but actually this is something we've given a lot of thought to. And that's kind of where we've landed at this point. Okay. KG 2022. Why do we take medications to lower our heart rate when we are standing, etc.? Isn't that a warning sign that we're not getting enough blood to our brain, and shouldn't we be paying attention to that? That I agree. That is my stance. Yes, absolutely. SLB Susan. All right. Could the supplement? Oh yeah, supplement. So people say this one differently. I'm going to say it my way, and you're going to say I'm wrong. Pycnogel help with cold hands and toes, claim to help with blood flow, or would you consider it symptom treatment? I would, for most cases. Doesn't mean that it doesn't help though. I think it's like pycnogenol though, but it just depends. So here we're starting to get into more like peripheral signaling rates, and then understanding like why is it doing that. And that can be different. So things like Raynaud's or peripheral blood flow. A lot of people get super into nitric oxide as a model, but also like we make endogenous nitric oxide. So then the real question is, why aren't you making it and why aren't you distributing it? I think that's pretty useful. But I don't think you're probably going to hurt yourself for most people using things like that. But yeah, maybe so. I think you just risk reward it. Sometimes the supplements, you can try a bottle and see if it helps, and if not, then the cost wasn't too high, as long as you feel like it's safe in terms of risk reward. So yeah, which had all sorts of things. There are different ones that people use from different. Every brand has a different name, but these are usually they're kind of combined usually with other things that are in a similar vein. And some people really like them. Some people don't find much benefit, but supplements make it easy to kind of try things a lot of times. Dancing P has diagnosed with vestibular migraine as well, but I have a headache constantly and head pressure. I'm glad you spoke about it. Yeah, that's just my feeling on it. I wouldn't say that everybody that gets a vestibular migraine diagnosis is wrong, but I also wouldn't say that everyone that gets it is right. It's worth kind of really diving into. QQ, if you slow the heart rate too much, will it cause breathlessness? Sure. It also, if you speed it up, it also causes breathlessness. There's like a sweet spot. We've talked about it in the past. I think you've been on, but we've talked about the fact that breathing is like the central generator of the rhythm for cardiac output too, for your heart rate. So they should be coupled together. So anytime we start to see these big swings and deviations in heart rate or breathing, they'll start to decouple and then the phase shift happens, and that doesn't feel good. So we kind of just want them all to be able to move in sync with each other, whether we're working harder or whether we're resting. If we start to exceed those ranges, then they get out of tune. Dancing P. Have you heard of cases where SSRIs worsened POTS or dysautonomia symptoms? At the beginning of my journey to diagnose me with anxiety, welcome to the team on that one, and then push the SSRI. Yep. I made my heart rate go up and made me feel worse. Yeah. It makes people do all sorts of things. So it's not very predictable what it's going to do from an autonomic perspective. And that's been my experience where people on them, some people say like, hey, it's great for me. But some people have all sorts of wild responses to it that it's hard to know. But anxiety is not my true diagnosis. I think that's usually right. I'm sure this happens with many others with POTS and dysautonomia. Yeah, almost everybody feels like, maybe not. Maybe if we actually measured it, it'd be like 80%, but that's a lot of people get some sort of either, it's anxiety, chill out. It's anxiety, here's a med. It's anxiety, go do CVT. That is kind of the case. And even there's a lot of people who are like, it's POTS. It must be that you need to relax your autonomic nervous system centrally, which for a lot of people is not the case. So if you have these problems, these symptoms, there is a strong reality that you should feel anxious. There's something wrong. Your body's trying to say, hey, pay attention, there's something wrong. So for a lot of people, trying to address the anxiety and like woo-saw your way out of it isn't the right thing for a lot of people. Now, there are other people where they do have just a generalized anxiety that is hampering their life and giving them a tough time. In those cases, yeah, we got to do things that help. Use some frontal activity, calm that thing down, being able to suppress that limbic output, normalize it. That can be really useful. So I'm not saying that either is hogwash. We just got to solve the problem. That's the correct one and not jump to conclusions. Mathieson said, if a person has gut issues from dysautonomia and also has slow methylation, would you think that their MCAS would resolve when their neuro issues are treated, or, good use of or would they still need to treat their slow methylation? I guess my question is, does the slow methylation resolve or become less of an issue once the dysautonomia is better? Great question. My experience, so methylation, as it's often referred to as, is through a genetic portal on capacity. It's just the ability to conjugate in the liver. So if I've got a paucity of activity in the autonomic system, there's a likelihood I'm going to be bad at just like most things that are energy related. So digestion being a big one of them. Anytime, so there's like a general rule that we use where anytime you've got to steal some blood from somewhere to support another activity, you're going to steal it from your gut. So in something like POTS, if I'm stealing blood flow from my brain, I'm also going to really have a tough time perfusing my gut correctly, and therefore I'm going to start to develop nutritional issues. I might develop immunological issues and create sensitivities, and I might see changes in my ability to use substrate appropriately to be able to do those things. Easy ways to check is you can take a methylation support, see if that helps your symptoms, and you can use that for a period of time as a corollary while you're working through those symptoms. Not such a big deal. We get those from things like cruciferous vegetables anyway. You're just taking in a bigger load in a processed version. Okay, so you can do that. That's not a big deal. And then over time, as that gets more resilient, you may notice that the necessity for having to tweak all those dietary elements might become a little less severe, and you're kind of leaning on those things can become less. And we see that quite a bit where people come in heavily supplemented, very restricted diet, and as they get better, they just kind of are able to loosen those things up more and more. I still advocate for an organic, whole food, local, super clean diet. I think that that's just good for everybody. But a lot of people are so dang restricted. Today we had a no dairy, no gluten, no sugar, no eggs, and it's just like starts to limit your ability to actually get a nutrient. And we can see, we saw today that we started to see some evidence of malnutrition with the buccal mucosa as well. So something to consider. There's a line between elimination and proper nutrition. Cool. I was in I think this is University of Texas Southwest study with IVIG for POTS. The control, albumin, was better for me. My morning heart rate is still in the 130s. So these are basically, for people that don't know, IVIG is kind of like a mercenary immune system. You're just using somebody else's immunoglobulins and seeing if that has an effect to reduce immune complication. Morning heart rate in the 30s or in the 130s might suggest that we didn't lick the whole problem. There could perhaps be something else going on, but we don't know based on that data point, but it's interesting. Matheson, I've heard POTS patients are frequently asked if they experience blood pooling, but what if the blood pooling only happens in very warm weather and otherwise the fingers and toes are cold and pale? Cold and pale is really common. Really, really common. And you can just think about this as inefficient blood flow. All right, so pooling is one way to describe it, but you can either send too much or too little to a particular area, and it just depends on what area you're judging as the catalyst. So a lot of people will experience that they get cold, pale, blue, purple, red, all sorts, like a myriad of different things. Sometimes their hands will be sweaty or their feet will be sweaty. Sometimes they'll be super dry. These tell us about the differences between the ability of the cortical maps to accurately push blood flow to an area, or if we're having a catecholinergic response. So we use all this data for everyone. So that's just part of the workflow. If we're cold and pale, then we also want to note if they're sweaty or if they're dry. And that helps push you to another layer of nuance. Okay, Dasket, back for more. 1,200 milligrams of coffee. Stopped to do dehydration issues. That makes sense. I started getting severe adrenaline spikes, blood pooling in the hands and feet. When in the up position, I also get adrenaline spikes after eating. How long has that been going on? I'm interested about that. Christy Lee, learn to stop blaming myself for not tolerating meds. If anyone else feels the same, it's not your fault. Your body's just asking for a different approach. Well said. I love that. You guys are very helpful to me and to each other. I really appreciate it. Yeah, I mean that sometimes it makes you feel like you're doing something wrong and you're not doing anything wrong. It's just not the answer for you. Eileen agrees. Double H, actually, I'm not. Double H was asking about the clinics in another state. I'm not kidding. Well, if you don't want to open a new clinic, and I understand your point, why don't you teach others your approach around the country, and you can consult on newer complicated cases. So I taught a course a few years ago. It was a 150-hour course for functional neurologists that was available through the Carrick Institute. I taught that for 150 hours. We did 2 years of we did 2 grand rounds where people came to the office and watched me work through cases as I described what I was doing. And that's been really useful. And I do consult with a couple different practitioners around the country. That part works great, but it's also hard to control outcomes. So in that model, you really have to have people come and spend time. It takes time, years, amounts of time to get good at it. And having them do that in a centralized location is the best. That's actually the way I learned as well. I got to spend time with my mentor working directly. And I had already practiced for 4 or 5 years before that. And thought I was good, and then went and did that, and it was like my whole world changed. And so for me, I am interested in trying to replicate something like that, where we can make sure that we are cranking out super high quality people. Not to say there aren't high quality people in the world that are doing these things. There's some brilliant people, some of whom are probably way smarter than I am. But in the way that I can control it, it's easiest if we do it every day, learning along the way. That's my perspective. I appreciate wanting to spread it out. I love that idea too. We need somebody that's built for it better than I am, maybe. Corey's goading me. Dallas Fort Worth would be a great place for a second clinic in the future, of course. Melissa says just clone yourself. That'd be great. Thank you very much. Oh, you guys are being too nice to me. Christy Lee says, yeah, we need more in the world. We'll keep working on it. Okay. Thank you guys for that. I really appreciate it. Hello, doctor. I am Hajar, residing in France. Beautiful place. I started having some neurological issues recently. Here it is so frustrating to get an appointment with a specialist. Can I discuss my case with you, please? That would be fine. I'd be happy to discuss. What you can do is just reach out. Maybe Dr. Ginya is here. She could help reach out, and you could set up a way to do that. Also, Hajar, it is very late in France. You should be in bed, but I love that you're living it up out there. So, yeah, just reach out to us, and we can try to find a way to make that work for you. Double H, nice idea about Dr. Clone. How old is your son? Oof, we got a long way to go until he's ready. Although he's a super smart kid. He's like my little engineer. I love it. And then I got 2 daughters as well. I'm very lucky. Got great kids, super smart. And so hopefully they do something they love someday. Ray Hughes says, what? Hold on. He says, what remake POTS medication? But I don't think that's what it's supposed to say. What something POTS medications? I was put on fludrocortisone steroids to raise my blood pressure. I was still tested, told I had POTS. Yeah, I mean, that's so fludrocortisone is a volume expander. So you hold more salt, which then makes you hold more water, which just makes it so your blood volume goes up, so that you don't have to be as accurate at moving it around your body, because you're just trying to like fill yourself up, swell it up. It doesn't replace accuracy, but it can make it so you don't have to be as efficient. Dancing B, I really appreciate the work we do with patients who have POTS and dysautonomia. Respectfully, I'm curious what inspired you to focus on this area. Okay, yeah, that's a good question. I'll share part of it. So I'll share part of it because I know people have a lot of questions, and this is indulging me. I started with people with dysautonomia out of the world of concussion. So a lot of the work that I cut my teeth doing was in post-concussion syndrome, people that were having a hard time, long duration concussion. We still do a lot of that. But there was a thing that we noticed, that people that had concussions also started to develop these autonomic problems. And by addressing the issues that were related to brain, the concussion problems, we saw changes in the outcomes in the autonomic cases. And it just so happened that a lot of people had a hard time with the autonomic cases because they don't heal as well. You can't just exercise them. They don't do very well. And so we just got kind of specialized in that. And like the more I did it, and then would run into cases where I would do that same thing. I would try to just solve for what we would solve for in a concussion. And I realized that there was this cohort of people that like I just couldn't get all the way there with. And then I had to do the uncomfortable thing of having to, like, it just drove me nuts. And so we just kept trying to figure out more and more and more to understand how to help people more. So it was a period of time of just kind of grinding out, trying to figure out where we were wrong and trying to figure out how we could do it better. And just a lot of that for a while. And then started to teach about it and consolidate that. And then I had some things in my own health that happened along the way that gave me a different perspective. We'll talk about those in a different format. Just gave me a different perspective on what people were going through and allowed me to think about it a little bit different way. And because of that, had some changes in the way I started to think about that. It really opened up the world for me in being able to serve in this space. So that's like the kind of mysterious version of that. Sorry about it, but yeah, we'll talk about it in another way later. Okay. What are POTS medications? There's a bunch of them. There actually are this many, which is 0, that are on label for POTS. The gold standard treatment through the consensus guidelines is exercise. And so what we are doing is actually exercise, but rather than thinking about it as cardiovascular exercise, we think about it as brain exercise. And if we can do that, or nervous system, or it's not just brain, we're targeting the exercise toward the area of deficit rather than just using exercise writ large, if that makes sense. So there you go. Double H, anything small is better than doctors who don't know what autonomic means and we need to explain it to them. I would agree with you there. Back to our caffeine question. We've been going on for 6 months since quit. Before stopping, I would get severe crashes after eating, where I would get severe sleepy, carbs or not. Yeah, we might have to look at like, so if I were looking at caffeine in that way, I would actually first make sure that glycemic loads were in check, like we weren't dealing with what we talked about earlier with any hypoglycemia problems, just because of that kind of jump start into that adenosine system. Okay, so I know that's convoluted, but there's a lot to that question that's hard to answer in a chat. Ray, do I do telemed? I do not. I don't do telemed because I'm not good at it. So where I am best is when I can observe people and actually test them and see what is going on. That's where I'm most useful, where I can test, see it, observe, interact with people, and figure out how to solve it. Ritvik, sorry for all the questions. Don't be sorry, Ritvik. Great questions today. Last one. That's famous last words. I've noticed that activities like showering, which are challenging for POTS patients, take my HRV for a few hours to a day. Does that resonate with you? It does resonate with me because it's a stressor. So if we're having a hemodynamic challenge where it's hard to get blood in your head, and then we say, you know what, let's also take that blood and put it somewhere else into your skin to manage the heat, then that's a major stressor and will actually often cause further hypoperfusion that can take some time to recover from, similar to why people feel like the delayed effects of exercise, or why they feel the delayed effects of mental activity, or like climbing up the stairs, or whatever the thing is, because they're challenges to a system that's already struggling. Good question. As always. You knew that though. Nomad Over Normal says, if a hot shower or summer day causes blood pooling, could heat be a good treatment tool if you have constriction in that to create dilation there? I do actually like using heat when we can, and we'll use it in a way where we kind of use heat and cold at the same time. If we have constriction in the neck, we want to think about what is causing the constriction. So is it the artery itself that is creating a spasm, or is it something that is compressing against the outside of that artery? That kind of makes a big difference. So if it's something where we're getting that constriction there, we want to couple it to looking at what's happening with CO2 ratios, because when CO2 levels start to drop, we'll get that reflexive constriction. So we want to create a normal CO2 rate, and then we can do things like you're mentioning, adding heat. We use exercise as well, which can generate the heat. Sometimes when we're doing exercise, like you see us do laying down, we will we'll use a class 3 laser over the carotid arteries as a way to stimulate or to irradiate the blood as it's coming through as well. So there are times when we get a little bit nuanced with that, but yeah, absolutely. You could use heat as a way to offset some of that dilation. Now, one thing to remember about heat and dilation is that it's mostly going to be in the cutaneous dilation or the peripheral dilation, so like in the skin, not so much in the deep vessels that are coming up through, because that heat exchange happens primarily in the cutaneous vasculature, not in like the deep muscular vasculature. The deep muscular vasculature is where we generate the pressure from, and then we dissipate it into the cutaneous system for heat. So we want to, it's hard to think about it that way, but you kind of have to break them apart. And one is like in the skin is kind of thermogenic temperature, and then deep in like the muscles and in the bigger arteries, that's where we're generating pressure to move it around the body. Good question. Crushing it tonight, guys. Way to go. Okay. Ganashayam says, thank you so much. Learning a lot. Please don't stop sharing. Thank you so much. Double H says, you guys saw that I was closing in on the last couple comments and then just hit the ground running. I love it. I'm going to go till 10 and then I got to cut it off tonight. But Double H says, can smartwatches have any help with all fun symptoms, or it causes more stress and anxiety and keeping monitored? This is a great question. It can go either way. It kind of maybe depends on your personality a little bit. I know I am the type that if I notice something, like if I have an arrhythmia, I'm gonna be checking my pulse all the time, every time I think I feel one, so I get obsessed by it, and then it also almost becomes like, you know, it starts to become its own problem to deal with. It's just like checking stuff all the time. If you're a person that finds that you can use it and not abuse it, then it can actually be helpful because you can track over time if things are changing in one way or the other. And being able to track that can help you understand a little bit more about what activities may make you feel better, may make you feel worse. How are you recovering, sleeping, etc. Recovery is actually a big component for a lot of people, because the same way we think about like the capacity that we have to do things during the day, that's an active process. Sleeping or recovery is also an active process. Like it's not just the default state. It has to have its own sequence, like it has to be in time, and it has to use all of the orchestration to be able to make that work. So the same way people can have problems with doing things in their awakening hours, they can also have a dyssynergy in the recovery process. So being able to like work a lot, but then also being able to fully recover or charge the battery, so to speak, can be difficult for people too. So using those types of measurements can help you understand a little bit about how that goes. Also, though, some of the HRV measurements for people that don't have a normal functioning autonomic system can be a little bit irregular or misleading, because it's kind of built on some assumptions for people that are a little kind of tend to be more in the normal part of the bell curve. So really good point. You just got to figure out how it affects you. If you notice you're getting obsessed with it and it's not useful, get rid of it. If you're finding that like I can collect data that helps me modify my behavior in a way that's useful for me, then that's probably a good person to use it. Okay, Matheson says, I'm interested in hearing more about what you shared in your Instagram story today about getting lightheaded when your posture is upright and feeling better when slouching. Yeah, good point. So a lot of people will notice that like there's more energy that comes with having to maintain this upright, even though it tends to be better for people. Whereas in that slouch, you're just kind of like hanging on your bones and there's less energy involved. Some people will also notice that if we have, like, for example, a lot of people will notice that when we tip their head back, they might occlude the blood flow that's coming into the brain. So in those cases, those people may choose to actually like reposition themselves away from that posture and like tip it forward. When they notice that, we might be like finding a spot where they can function, but then we might be sacrificing some things in terms of like the ability to breathe, or the ability of like the heart to maintain normal contraction, or et cetera, et cetera. So there can be a give and take with antalgia, or things that are painful as well, especially if we've got like a whiplash injury. Somebody may avoid the pain, but it may be restrictive to the blood flow as well. So it's kind of like trying to figure out where the sweet spot is. Ideally, we don't want to have people have to be in this perfect posture to be able to get some juice. we want them to be able to kind of be able to experience all of what's available in human activity without feeling crappy to do so, right? So if I've got a dancer, for example, I don't want her to be stuck like this because she's afraid to be able to get blood into her head. I want her to be able to get the same amount of blood when she's doing all the things that she can do while she's dancing, and that you have the variability to be able to take advantage of that. So normally we shouldn't restrict blood flow at all during the movements that are available to us. So you're actually trying to solve for, I want to do all the movements and also not restrict blood flow. Okay. Sunda says, is food tolerance part of POTS, or it could be something else? It can go either way. A lot of times though, the trend will be the longer period of time that we're having altered perfusion in the gut, we are more likely to create problems with barrier systems in the gut, which can create food intolerances. We're more likely to change the pH in the gut, which can change the microbiome. And then we can kind of devolve into things like SIBO or other infections that become opportunistic because the environment within the gut changes. Blood flow can be a massive part of that process for people, especially the longer period of time that it goes on. And I think a lot of people on here can probably relate to that. Susan says, my 34-year-old daughter has POTS and has severe neck issues, can't move up or down, limited side to side. You mentioned that neck can be related to the POTS. How do you determine that? Well, we do bedside orthopedic tests where we look at the function here. We measure pulses that come through. We look in the eyes to see if we can see venous pulses or if we see arterial compression. We do OCTs of the eyes to look to see if there's pressure changes in the skull. We use transcranial Doppler to look at blood flow into the brain in different head and neck positions. We do balance testing and oculomotor testing to look to see if we start to create proprioceptive changes in the neck that cause problems. What else? We look at just simple bedside exam where we're looking to see if the spinal cord is involved or if peripheral nerves or arteries are involved. So we just kind of run a whole gamut of taking a deep dive into the neck to understand what is going on, along with the other things, not just the neck, but we're just trying to cut through and solve that problem. Susan said, thank you very much also. Sundas, as I developed POTS-like symptoms last year after a C-section and severe intolerance with eggs, cheese, processed food. Oh, so that's a continuation of that. Just kind of giving some color to it. Yeah, and then also going with that though, then we want to see if any of that is postpartum related. And then obviously C-sections, hope baby's okay, hope they're healthy. Can come with their own, difficulties as you add medications or anesthesias or just from injuries that can occur from the C-section themselves. Atara says, I've been having a drop in oxygen levels when standing and sitting along with head pressure. Is this a normal response? Anything I can do to ease it? Anything you can do to ease it, I don't know. There's not enough variables to know that. But if your oxygen levels are dropping, then we want to look at the saturation that's happening in the lungs and make sure that we're having normal exchange there as a first step. With head pressure going up, then also, so long list of things there, because if we're getting more pressure when you're standing versus laying down, so we got to understand a lot about intracranial pressure, also cervicogenic pressure, what's going on with hemodynamic pressure. So there's a lot of investigation to go into that one. Yeah, so we need to dig on that to be able to see why that's happening. Ritvik noticed he feels better slouching too. Yeah, sometimes that's just getting into that sweet spot of where it's working for you. Oh, but also, it's tough on the muscles. Becky, when the temperature gets slightly warmer, I get a minor hot flash, but also when I turn the lights on in the morning, I get cold almost every time. What might be the cause? Great question. Probably two slightly different things here. But getting cold every time you turn the lights on, some people will do that. You notice with the light response, it'll make them yawn or cough as well. But that's interesting if we're starting to get a surge of activity there. And then we look at kind of pupillary responses related to that. Melissa, can symptoms improve enough, even without correcting a kyphosis, another poor alignment in the cervical spine that is large contributor to this function, to the dysfunction. You can. So there are people that can exist with the kyphosis that may or may not cause these types of symptoms. It's just in a particular person, does that yield those outcomes and responses? Like, are we having problems generating pressure, like a Valsalva, or can we take just enough load off of that cord so that we can let that signal transfer without fully addressing the kyphosis? So there are a lot of people that walk around with a kyphotic neck that don't have symptoms. It just depends on the person and how lucky you are if you have those symptoms. But you may find that even just changing some of that proprioception, changing the structure underneath it, can progressively start to change that even as you're working through that curve correction. I think it's worth correcting though. Well, let's see. Okay, I got a couple more minutes. Jo, thank you. Dr. You and your generous sharing, a blessing. Thank you very much. Sundas, please advise some exercises and lifestyle changes that can help. Can't do that. We can't treat over the internet. I'm sorry. I know that I would love to be able to, but it's not available. It's not allowed. Roots, Heart, and Wings. Like that name. I'm on metoprolol for about 6 months. Most days my watch doesn't beep over 120. Some days it beeps a ton. Why could this be? It might be because your heart's trying to help you out. I'm not sure. There's not enough information, but a thing to consider would be if it's going up and over, even on the meds, you may be trying to compensate for another problem, and it may be worth kind of like looking over this case we looked at earlier. I think that might be useful. And Dancing Peace says thanks again. Going to call tomorrow to get more information about coming in. I hope whatever happens, I hope it works out. I know we've seen you here a lot, and hopefully it's valuable. Thank you, HH. Thanks for saying thank you. Yeah, glad to help. I know some of the questions that we get are like, you guys are wanting to get an answer for you. I don't blame you. I would probably feel the same way, but I'm just in a pickle where I can't do that, number one, because it's not allowed. But then number two, in order for me to do a good job for you, if I really want to try to diagnose a thing, you have to see, I got to see it and I got to get it right. I don't want to lose for you. So those are the kind of the two reasons why I won't. It's not because it's a bad question or I don't want to answer it or we shouldn't answer it. It's just like that. Those are the handcuffs that I have to wear to do this. So I hope you understand that. But I hope we do at least, the goal of this is to at least start to bring up some topics in ways where we can think about questions in new ways, think about problem solving in different ways, and carry the conversation further and further. I think we've been successful at that because you guys are asking great questions, and these are not questions that people asked even a year ago. For me to go have these conversations, it was always starting from square one. And just seeing this group be able to assimilate these things is like a dream come true for me, because I feel like we're moving the conversation forward. And I just want to thank you guys very much for being here and you just participating in this, even though hopefully there's benefit for you. It also creates benefit for the people that watch it, because you are literally setting the standard of the questions that people will get to ask and answer that propels people forward. So I just wanted to take a minute and say thank you for that. Okay. So thank you so much. I'm going to answer these last two quick ones. Can degenerative spine disease cause an increase in tachycardia? Yeah, if it creates problems with transmission through the cord or on the outside of the cord, for sure. And then Ritvik says, thank you. Thanks to your family for letting us take that time. Thank you. No matter what, if I stand there as tachycardia, I wonder if there's normal for whatever form of dysautonomia I have. If you stand and you got a lot of tachycardia, let's figure out why your heart's beating fast, what it's trying to compensate for, what it's trying to save you from, and then work from there. And SLB says, thanks to all of you in the community that are helping each other out. So I appreciate you all. Thanks for the session. Please make some arrangements for online consults as well. I won't do, I know we get probably tens of requests for that every day. I probably won't be doing online consults until there's a technology that would let me do that. Until then, I'll have see you in person, be able to examine you in person, and I promise that's the way I'm the most useful. So, Tracy wants to know, will I be bringing the mullet back? This hair's already long enough. Thank you very much. I would probably cut it, but Claire likes it, so we keep it and we just try to manage through it. If we've got some ideas, let me know. We're always trying to find something to do mullet. My son wears mullet strong. Won't let it go. He's a hockey player. So he just loves that flow out of the back of the helmet, and we support it. So anyway, thanks guys. I love y'all. Thanks for being here. I'm gonna go to bed. Some of you I will see tomorrow morning, ready to rock on a Friday. Others of you, if you have any other questions, send us a note or an email. And if you think this would help anybody, please don't be afraid to share it, please. With that said, have a great night, and we'll see you next